we've been talking about all the studies we have done and the gaps in services. We have been looking at the demand and the lack of supply, and putting an economic perspective to this, we have to talk about balancing the supply and the demand equilibrium. And part of the issue then will hinge not only on financing, but finding all the resources, mobilizing community resources, human resources. It's not just about building physical buildings and facilities, but the right siting, the right type of mix to really cater for different kinds of needs at different levels. So it's a whole plethora of needs. So I'll just go around very quickly to get from the speakers. How do you sew it all together? We are talking about so many problems, and we need to integrate it. Can you expect integrated policy, sort of a whole of government approach, the different agencies coming together? So part of the problems you see is that there's so many silos here in our system. You talk to one agency, they've got different KPIs. You talk to somebody else, they're watching a different bottom line. So how are you going to get all these people to incentivize them to work together? That's my question. How are you going to get all the different needs to be part of this integrated whole of government approach?
Maybe I'll start first. I think the first thing we need to do is just to get real and to stop pretending that the family can do everything. And the reality is that the modern family just cannot manage elder care on its own. And there's nothing wrong with that. So to stop moralizing about how your children are bad children, if they can't step in to look after you in your final stage. And I think then we can start talking.
Well, I had thought that the Ministerial Committee on Aging would be one place where government could get together and actually, discuss these issues. And they've made some very good recommendations, but we seem to be really lacking on the implementation side. So I think maybe increasing that dialogue with the policymakers at that level, and then working across barriers, boundaries, that would be more efficient.
If you recall, I did say that in 2008, the positive statements for hospice came out. And if you recall, that was the year when the Prime Minister in the National Day rally speech made the statement that there would be more support. And 4 years has passed. Why do I go back to that? We need political will. We also need action. And I think one of the reasons, besides the fact that hospice has been a unity, we'll take I talk about hospice, but the others can follow from the example. Hospice has been successful is we don't care what the government said. We just went ahead and did it. And of course, Leng Foundation, Shaw Foundation, biggest beggar in Singapore. I inherited Dr. Ee Peng Liang's role of biggest beggar. And we went ahead and did things. If I tell you that 20 years ago there was zero funding for hospice, we went ahead with zero funding. Today, most hospice charities are funded to the extent of about 30 to 50%, but still not full funding. So sometimes activist action has to set the way forward. And that has happened when I belong to. And when that happens, then you're forced to start to give 10%, then 20%, then 30%, then 50%, because people are using it. Talk at university level, at research level, ain't going to, all right?
Dr. Seet, you are a politician in government. Remember, as the first woman minister, you helped to set up the NACFA, the National Advisory Council, which predates the Interministerial Committee. In fact, the concept was the same. You're trying to integrate family policies and to anticipate some of the aging problems. And we had subcommittees for housing, and I chaired the committee on financing residential care. And all these concepts were were brought up and we discussed. And in fact, you were trying to push for a ministry for aging. You probably, if you had stayed on, you'd probably be the minister for aging. But it took it took many years before that concept was realized. And we have got committee after IMC after IMC, policy, committees after policy. And I've been reading the reports and following all the recommendations. It's the same thing over and over again. So when are we going to put all this into action? It's happening now. So last flurry, maybe because the electoral process has actually shown the signals. So other than political will, I think there need to be a bottom-up feedback as well. The demand has been expressed not only by academics, but the academics can get the data and the evidence. We're also evidence-based, and they continue to educate and to stimulate discussion. But I think it has been taken up by the population at large as well, the electorate. Would you agree as a politician?
Yes, I totally agree with you. Kai Hong, my political career stopped after national service, 3 years exactly. So I did national service and I was not given an opportunity to follow through. And I think that there must be political will. Singapore cannot say we do not have money. We cannot say we do not have land. We are saying we have money, but. We are saying we have land, but. So the political will must be there. And sometimes political will needs a kick from activist groups. That's all I'm saying, okay?
What about from the CPF perspective? I mean, you were quoted recently that there's enough, but it's all locked up in assets. So I'm just wondering now, for the average Singaporean, how going to unlock with some change in government policies, to provide support, financial support for this aging in place?
One very unique feature about the elderly in Singapore compared to, like, say, US, many elderly, they are homeowners. But I think most of us would have taken that for granted. If you are a elderly without a home, you would have to spend on renter. Now, you look at the household expenditure survey, 44% of the elderly household expenses are all related to house. You must be thinking, I don't pay rent. How can it be 44%? It's because in national income accounting, there is this concept called imputed rent. So for owner-occupied homes, you are implicitly saving on rental cost because you are homeowners, right? So you do not own a home, 40% of your budget will go to rentals. But the nice things about a lot of the elderly in Singapore, they have significant savings in rent. But this concept is not normally spoken of. People just say that, oh, I don't have enough money for my retirement. But many people have overlooked the fact that by being homeowners, you are actually saving on rental cost. I'm not saying that inadequacy is not there, but there's actually opportunities for people to monetize. For the current elderly, not many of them have a lot of savings. It's because the accumulation tend to be quite low because wages were low when they were in the during the working phase. But for the current young people, as long as you have continuous good employment, I'm not supposed to talk so much about this. As what the minister said, there will be enough. The paper will be made public very soon. We are just cleaning up. Yeah.
There are a lot of assumptions there. In terms of monetary value is there. It's the question of how people unlock it. Because there are a lot of cultural considerations.
Yes.
Yes. Crest and so on.
Yeah, I think a lot of issue is that people do not take monetization well. For example, let's say we downsize or right size from let's say 5 room to 3 room. 3 room is just quite nice. But if you are in a 5-room flat, you have a bigger space, your furniture tend to be bulkier. So you right size to 3-room, you have to give up quite a lot of your things that you own, which can be very painful to seniors. So when you talk about like right sizing to a studio apartment, it means that you have to give up even more, because we from your paper presentation, space is really an issue. So I think there's a lot of a psychological factor involved.
I'm going to say a real problem. 20 years ago, you asked me to chair a subcommittee for residential care and housing. And I said, what on earth has they got to do with healthcare financing? But the more I look into it, when we started having those meetings with the different government agencies, we realized there were a lot of problems. For example, we were talking to an ex-director of research from HDB, and she turned around and told us, I'm so sorry, we're not a welfare agency. We're not there to provide housing for all those problems you're talking about. We are here to provide to actual demand. And that time, it was a young population who want bigger and bigger flats. So don't tell me about piloting, innovative housing design. This was like 20 years ago, right? So that was basically, the door was closed, right? No point anticipating and the problems until you reach, when you cross the bridge, when you reach it. Essentially, that was the message. Now the bridge is behind us. And we have crossed. We are still trying desperately now to find all those intermediate and long-term care facilities. So coming back to then the question of design, as you rightly pointed out, the right type of design, the right siting to meet needs. Now, how is that all these have not been featured in the things that we have built? We're building for a different generation with different needs. And part of the problem is when we really asked people what they really wanted, it was the kind of dream of private housing and condominium, and everybody was going to upgrade. So the real issue is that, are they thinking now of, not downgrading, but what is the word you use? Right sizing for real needs of the period of aging in place. Can you say from a sort of a cross-cultural perspective, from the studies you've done in Japan or Korea, what is wrong here in Singapore about our society? A preference for different kinds of housing.
Conducted this project, actually I visit a lot of places overseas, such as US, Korea, Japan, Taiwan, Hong Kong. Actually, studio apartment is very unique, in terms of culture and in terms of some system. And good things, we try to integrate with the physical space with the social services around the block. That's a good idea. So, when you think about aging in place, today, within short presentation time, I just focus on the environment issue. But philosophy is first. Whereas you have to think about, regardless of policy, regardless of program, regardless of activity, whatever. If you are working in aging area, think about what is the ageism. So, for example, the place, you're asking about what is the good size. Why we have to think about good size only for old adults? That's, question to everybody, not only for old adults, If then we have to think about living alone condition, not just, for old adults. If you are single, although you are younger generation, right? But, if you are getting older, you need a really smaller space, when you need, more space when you are young. So what is ageism, So, returning to your question, you think, what is the right size, in studio apartment? So, please don't think about aging itself, Think about living alone situation. You have to maintain some space for your life. That's a starting point. So, when you think about some environment issue, and combined with the aging, we have to think about some universal concept, not only for old adults. So, today, I didn't go through the concept of a universal design, but universal design is for everybody, regardless of your age, regardless of your disability. That's a starting point. So, well, I'm not sure, in Singapore, how we really, reduce some discrimination, against the aging. But in Asian country, still we have some discrimination about aging. We think, olders are dependent, or, when you ask some simple question to, young generation, what is the image of, old adults? Nowadays, many people think like active aging. It's a kind of a transition, But just a few years ago, they symbolized dementia, as an older adult. That was our current situation. So I cannot say simply what is the right size for the studio apartment. Yeah, still we are try to identify. But you have to look at some situation in here. Although studio apartment designed for older adults who are living alone, but we noticed that many older adults need some help from maid. That's the Singapore culture. If then definitely we have to consider some space for maid, for them, to actually facilitate their real life in the place. So I dare to say the space is not enough. That's my personal opinion. And compared with the other country, studio apartment is too small. No space for storage, and cause a lot of clotting problem. So I cannot say that's really right space. But this is so far my personal opinion compared with some other countries. Yeah, I can show more empirical evidence from our researchers. So eventually I can deliver more confirmative recommendation.
Thank you, Dr. Tong. One final word from Dr. Thang, Leng, based on your comparative studies with Japan.
Well, actually, I have other points to make.
We have 50 minutes left for the general discussion and
Sure,
Q&A.
sure.
Yeah.
Well, I think, of course, if you compare to Japan, Japan has senior housing from beginning, and they do also have they have public housing with senior housings. That one of the interesting things I feel is they would let one of the residents, for example, to be the coordinator, and the whole set of that alarm system will be in her house 24 hours. So I went to visit one of these house units, and she said it's very stressful, so she's not going to do it after the contract period is up. But it's important because if an older person do not open the house door for 24 hours, the alarm will be lighted up. So she will have to go and check what happened to, is the person okay, and so forth. So, of course, we know Japan is much more advanced technologically in dealing with aging-related issues, as well as in the houses for seniors as well. But I think these are some of it's good to look comparatively across societies to see what has been done, and I'm sure in due course our elder senior apartments, if they can look into adopting some of these things at sustainable cost, I think that would be very helpful to a lot of problems that we face now with seniors living alone. There are cases of people who die alone. When we were doing our survey, one of our interviewers had to help to call the ambulance because the residents were telling her that this person has not seen him for many days, and then in the end she was the one that had to facilitate and then call the police in and found that this man has died there for 5-6 days. So such things do happen, and I think we should try to avoid that.
All right, there's Dr. Fong An-Foon. Dr. Fong used to be CEO of St. Luke's Hospital. He's now an adjunct professor of public health. Thank you.
There are a lot of issues to discuss, but I think one of the very important one that I hope we can focus on is about long-term care financing, which I think we didn't have quite enough time to discuss. In my opinion, I think this is one of the most important policy issues that needs to be looked into. Because as you rightly say, our elder care is not very comprehensive, it's very limited. And I think with a lot of subsidy and funding going to the hospitals, it skews the population's utilization of health services. So I think the long-term care financing needs to be a lot more attention paid to it. And a similar population aging in Japan, they started adopting it. So is in Korea and other places. So unless the funding is in place, I think we will have more and more isolated programs. Whereas if you have a good national long-term care financing, you would encourage the industry to provide logistics and you give choices to their Thanks.
Basically, you look at the whole plethora of funding. It's rather ad hoc the way we've been going about it. Of course, WHO is pushing now for universal coverage or single payer system, and we have been fighting against trying to put into one single national health insurance scheme, which will politicize it. Yet, when we shifted more to a savings-based scheme, We forgot about enhancing that with a very good backup insurance. It was a sort of half-baked thing as far as I'm concerned. With MediShield, we have tried to plug up some of the loopholes, but with ElderShield, the initial opt-out was over 40%. I don't know what is the current opt-out. With 40% opt-out, do you call that a successful public scheme? And with a payout of $400 now per month, which was raised five years ago from $300, following a study by one of my master's students who happened now to be in the Ministry of Health. It was pushed up from 300 to 400. But as you and I know, the average cost in the market right now is over $1,000, right? So who's going to pay for that gap? And so you're not going to get the care. So you then compromise with very suboptimal care with maid care, right? With maid care. And if the maid is poorly trained, you end up either with maid abuse, or in retaliation, you get retaliation. The maid will be abusing your elderly when you're not around. Right, so we have to do something about this. It's not just the financing, but even if you provide the financing, if the incentives are misplaced, if all the money is going to go into the hospitals, there's no point having a insurance scheme. And insurance could distort it if you don't design it well. So I think we have to have a lot more discussion about this, and we don't want just insurance for its sake. Where private insurance comes in and create moral hazard and again create perverse incentives. I think we have to have the majority of the insurance in the public sector. And for the frills and the extras, yes, you can have private insurance, but make sure that the basic is taken care of. I think these are some of the considerations, and we need more discussion and more research on the whole issue of how to complement public and private insurance with savings and the other out-of-pocket co-payment if there need to be. Okay, anyway, I've talked too much. There's some question there? Yes.
Thank you. I have a query for the panel. We have talked about, we're just wondering whether we could consider insurers as service providers. I know in US, there are service providers who actually have taken up the role of insurers, so you sort of control somewhat, or they come up with health plans. I'm just wondering whether that's a possibility for us in Singapore, because you make sure you have all your checks and balances in place, that the quality of care is not compromised.
From my comparisons with the US, because they went for a sort of a managed care strategy, and even many of the HMOs, health maintenance organizations, are moving towards this sort of integrated aging in place, long-term care, and which they call SMOOSH, the social HMOs. It's not meant to be profit-making, and then there's a lot of capitation involved. In other words, you take care of the incentives, make sure the incentives is not there to over-service. You pay fee for service. Doctors would want to give you the latest drugs and do all sorts of newfangled, technology and investigations and so on. So the bill just keeps creeping up. But if you are paying the doctors on the capitated average cost per head taken care of, within a health maintenance organization, the theory is that the doctors will not have the incentive to over-service. Now, we don't know how that is working out well, but over time, you have the so-called DRG creep, The average capitation costs are also creeping up as doctors game the system and so on. So we will expect the healthcare costs would go up, just purely because of the numbers and the kind of technology being introduced on the supply side. We will. So be ready to pay more and more. But the question is how you're going to restrain the rate of inflation and to be able to make sure that it is spread out. The risks are all spread out. So you have to go for some cost-sharing collective mechanisms like insurance. But I would prefer social insurance rather than to push it to the private insurance. The private insurance can show innovations, can take off some of the weight, but private insurance should not be the major part of that financing. Then you end up with the US system where you spend about 20% of your GNP on healthcare. And it's so inequitable. Some doctors and providers are making all the money, plus the whole army of pharmaceuticals, companies, insurance businesses, and all the related industry. You don't need those additional transaction costs. When you cut out the middleman and you just say, okay, let's provide the majority from the public perspective to try and keep the cost down. I mean, in principle, it is there, but as a small country, we can manage it. Like you said, if somebody is going to, bring all the heads together and knock their heads together, we can get it bottled up. But somebody got to be a bad guy to do it, right? Rein in the private guys, rein in the private insurance, and make sure that the proper role of government is there. Government has to balance the public-private mix, not only in financing, but in provision, in proper regulation, and provision of information. Because without the data, you're not going to know where the right balance is. Without data, how can you plan? Even private people cannot plan well when government data is not made available to them in terms of how much to charge, what kind of deliverables and so on. So I think data is very critical, and it should be in the public domain.
It is shortcomings. Actually, to integrate long-term care, we have to think about how we can coordinate more diverse needs. As you know, long-term care always embedded in comprehensive needs from others in a multiple perspective. So I think, but this point is important, but to manage better
finance, actually care management is the most important. So we have to know about what kind of needs the older adults have. And then we, maybe coordinate some service, and eventually we can estimate the cost too. So, if I am not wrong, actually, in the United States, some liberal states, they have, very perfect case management program, which is PACE, as a one example. And, actually, this is, kind of a, semi-state insurance program, and they have the, the professional case manager, and they assess, all the adults' needs in terms of long-term care, and then they have the common database, and then they share with all service provider, including the, private, insurance as well. So, eventually, the professional case manager can estimate the total cost in terms of the, comprehensive needs, and then also eventually, the private insurance unit involved in, and then estimate.
This is the norm. I think for some of those private plans where you pay quite a lot, then you have all this proper case management
as I mentioned,
and
this
proper
is
placement.
Semi-private insurance, which means some portion actually state government is covered. Under the the Medicaid, the Medicaid is a similar concept of Medifund in Singapore, in the US. So it's kind of a corporate system between private and public. So the state government can reduce some cost, and then provide this more integrated care service. But the key concept, what is the more innovative idea? Care management. So I think that's very relevant in Singapore, because we, many helping hands in Singapore, right? In terms of a social service delivery system, we have too many helping hands. But we don't know who is the best, helping hands. Maybe it's a good time to, select, best helping hands. We have to have long, helping hands. So, so long helping hands maybe connect and coordinate, some helping hands, and eventually we can test the quality of helping hands, so we can provide some services through the best helping hands.
I see Professor Envy is very anxious now. Yes, Professor Envy.
Well. Paulin's encouraged us to think kind of new ways of looking at things. And Angelique has described something which, if it could work, might keep down the whole cost of elder care, because I've forgotten the figures, but the proportion of people in dialysis who really shouldn't be there because the condition should have been controlled earlier is really shocking. And I believe that we internationally don't look good over amputations also. But I grew up before there was a National Health Service, and I'm thinking of a way in which we can keep down costs. The primary health care before the National Health Service in the small town where I grew up was handled by the pharmacist. You didn't go to the doctor, you went to what we call the chemist. And he might say, oh, you better take that kid straight to the doctor. But more often he might say, try this for 24 hours or something of that kind. And as far as I know, nobody actually died because of this system. Also, we had the district nurse, who was what we'd here call the HNF. And if you knew she was going to see the old people next door on a daily basis, you popped in and said, "Bup, bup, 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 bup." And again she might say, well, go to the chemist. Or she might say, go to the doctor. I think the handling of these chronic conditions, a well-qualified nurse knows whether to just give another bundle of the prescription or whether to say, oh, I think you better see the doctor. Now, maybe in the polyclinics we could have different colored cards, and if the doctor reckoned that actually the next time you came you could see the nurse clinician, then that keeps down the queue for the doctor. Of course, if you're snooty and say, I want to see the doctor, okay, you get in the long queue. But I feel we should be looking at, with all respect to qualified doctors, we should be looking at the conditions that perhaps could be handled at a threshold by less expensive personnel and various things of that kind.
Issue of the incentives. You know, if you have perverse incentives that encourage people to institutionalize or hospitalize, and you don't pay well for those community support services, your 2 E's and the thought of going to a 3 E's is so poorly developed and so poorly designed. So you end up with the 3 M's absorbing most of the weight, you know, which is to hospitalize people until all your Medisave is exhausted, you know, and also your Medishield is inadequate right now because it doesn't keep up with the payout rates and the rates of inflation. So you continue to perpetuate on the supply side all these incentives to over-service in the wrong place. So let's not talk about right siting, where you have not incentivized people to provide the community-based services, right? And also, on the demand side, the incentives to patients and their family members, you know, to place them in the right places. I was surprised, like my father was hospitalized in a community hospital, I won't mention which one. I was very angry with the CEO. I said, how could you price your first-class beds more than the first-class beds in NUH? Well, it says very simply, the subvention from the government is so low, I have to rob Peter to pay Paul, right? So he plays Robin Hood there. But what to do? I know they are a volunteer organization. They don't have the money if the government's norm costs are not adequate. So there's always this problem, you know. And therefore, there will be people who will be penalized to help to solve what is rightfully government's role. So government, I think, is where you cannot just pass a buck and say many helping hands, you know, and then some helping hands who are more altruistic and humanitarian will be overstretched. While others are not doing enough, you know. So you end up creating perverse incentives, and you don't support and empower the altruism and many of the volunteer organizations, you know, unless you have adequate incentives and you pay them enough to keep them doing this kind of community service. So I think government's role is to really to be able to coordinate. It's not just many helping hands or trying to get the private sector in. The public-private partnership is not well balanced. You know, you have to bring in more of the non-profit sector in, and then to coordinate and to make sure that they are well supported, and not just to say, well, because one NGO is doing so well, let them raise more funds, and then all the money goes into that type of care. You know, which may not necessarily save the government money, but it doesn't save the rest of society. You know, the social cost that's passed on, and it deprives other people of that. Lack of public funding as well.
May I interject? I mean, you know, I'm a sociologist, right? So I keep thinking there are all these problems that the esteemed members of the panel have raised about how you have to beat the insurers and how you have to ensure that, you know, the incentivization works, but would all not go away if we just are willing to adopt a national care scheme for those who are 65 and above? Then in which case, then the government knows up front, right, that I have to take care of 20% of my population. So then they can start to plan the infrastructure to bring in more allied health workers. And then you don't have this situation of people trying to outplay the system because everybody is eligible. And won't that bring in an economies of scale kind of projection? I mean, I'm speaking very naively because I'm not trained in economics, so maybe the politicians and the economists can help me understand this.
Well, because I used to sit on so many of those government committees where we debated long and hard. Over 10 years, we weighed the pros and cons of why we don't want to go into that route. And I think part of the problem is we do not want to politicize. You know, if you have a single agency, it becomes a monopoly, and then there are a lot of complaints now why you have to have just one size fits all. And I think the politicians are scared stiff of, say, for example, with having a national health insurance, and look at all the national health insurance in the world, right? The political pressures goes to bear on this single payer system. And then they end up spending much more. So when I compare, say, Japan, Korea, Taiwan, on paper it looks very good. Single payer system, all your problems get solved. Then it becomes a real political problem. My good friends who are former ministers who have resigned a few times, Professor Yang from Taiwan, he comes back to me and says, he wish he has never gone to that route. He wish he has put into place a savings component, which is what we have done. Because the savings component takes care of the intergenerational transfer issues that many of these pay-as-you-go systems, whether it's insurance or taxation, would pressure the government of the day to keep on either increasing taxes or increasing premiums. So in the context of an aging population, it's clearly unsustainable. So if you go that route, so the sequencing is very important. So we have put in place the savings concept. But we have not backed it up enough with the insurance concept, But we have done it right by not putting insurance first. We put in savings. So it is there. So the question of tweaking and fine-tuning the balance, And the insurance part is very, 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 very weak in Singapore as compared to many of these countries. But having said that, then you say, well, is it time now? The government here has done a very good job in so many other aspects of planning. What about then coordinating all these different components of the system, Yes, we say you need cost sharing, we need savings, and then we need to bring in individual responsibility, family responsibility. That's fine, but please coordinate it a little better to make sure that the allocative efficiency is there. So another concept is, it's not just technical efficiency, We seem to do a lot more and we squeeze the resources. Very good technical efficiency, but allocative efficiency, there's a lot of duplication, a lot of the lack of synergy, there are a lot of gaps, All it needs is better coordination. We are very good at managing resources. Why are we not doing that enough for the health and social care area? That is my question. So I don't know whether anybody else has something to add on this. Okay, if not, we have time for maybe one final question.
If I may just slightly change the tone of our discussion, we've been talking about money and health. And you are talking about people who are coming over 65. And I think there's a lot people between 65 and 80 can actually contribute to the society, and we are not really focusing on that. And I think at RSVP, we really believe in active aging, and we became positive contribution of people to actually contribute to the society. And I think your statistics show a lot of people, they are coming in 65, they are coming in aging. They are coming in 65, they are aging societies. Is 65 really an aging society? There's a lot that people can really do and contribute. And as far as money is concerned, it's constantly being devalued. And on one hand, we tell people, start saving early, start saving early. And my money, which I start saving early, is going to be devalued so much that it's not going to really make any difference 20 years later in actual exercises. So at the end of the day, I think what we should really focus on, how to keep people happy, how to keep people can survive, how people can contribute, rather than simply looking at the end and say, what do they do in hospital, how do they die? Today's newspaper had an issue and says, today's newspaper says, in your last stage, would you rather stay under an oxygen tent or would you be rather kissed by your wife? And I think these are the kind of things we should really think. And today's newspaper has also got one more issue. The baby boomers are being totally ignored. Their views are not really coming into the picture. So at the end of the day, we should ask people what they want. And most of the people, what they want is a companionship, a happy life to be able to do. We talk about family, we talk about government, we talk about private sector. Somewhere along the line, we should probably take an integration of all these things so that at the end of the day, there is a shared responsibility of the family, the community, and the government together. And I think these are things we should really focus on rather than how to die and how to survive in hospital and how to get the money and all these things. Thank you very much. I'm sorry I changed the tone of the discussion a little bit.
Thank you very much. But these are exactly the kind of things we want to hear and want to discuss. But you were talking about happiness, and I just remember reading an email that was being circulated around a few days ago. Professor Yeoh, our professor of psychiatry, has been doing a lot of work on dementia And his recent study was very interesting. Say 20 years ago when he conducted surveys of the elderly in Chinatown, the happiness index was much higher, and yet they were poorer because there was a lot of social interaction, you know. But now he conducted the same study, he finds that actually it has gone down because people are socially isolated. They may be richer, but they're all kept in the HDB flat, and there's no opportunity for them to come out to mix around, you know. So that was a very, very significant thing that he saw. So we seem to be doing very well in terms of GNP or GDP, but what about the gross national happiness? Any other question before we close? I think we have had a very rich discussion, but we're just skimping on the surface, you know, and then scratching the surface. But there's a lot more we can do, and I'm sure you will want to support all these wonderful researchers here who are doing cutting-edge research, and I hope there will be many more forums like this where we will come and share and really have some kind of not just multidisciplinary but transdisciplinary approach. I've certainly learned a lot from my sociologist friends, you know, and the practitioners, and I would like many more interactions, you know, between the policymakers and the regulators, the practitioners with academics and researchers, and if there's any way in which you can involve the university and especially the health cluster of the Faculty of Arts and Social Sciences, please get in touch with us. So thank you very much for attending. Thank you very much.